Hello, everyone. My name is Michael Albrecht, my internal medicine physician, and I've already given one talk on asthma, the diagnosis part of asthma, and this talk is going to be on the treatment of asthma. In this talk, we're going to discuss how to determine whether asthma is controlled, define what treatments are recommended for the different stages of asthma, understand the use of monoclonal antibody medications used to treat asthma, and understand some things to do if asthma is not well controlled. The goal of asthma treatment is to control symptoms and to prevent exacerbations. Exacerbation is a fancy word that just means getting worse. So when we talk about asthma exacerbations, usually what we're talking about is a severe worsening of the asthma, including so severe that you have to visit the ER or hospital. And so we can tell if somebody with asthma has control of the asthma if they have symptoms that are infrequent, so less than 2 days per week, if they have nighttime awakenings from the asthma less than 2 times per month, they don't have any activity limitations, such as, when they're walking or doing the things that they want to do in their life. They require little to no rescue medication. They have no exacerbations, including ER visits and hospitalizations. And if asthma is controlled, step down of their therapy, which means less medicine or a lower dose of the medicine, may be considered. People who have uncontrolled asthma may need their therapy adjusted upwards, also known as step-up therapy. Doctors often use just standard questions to assess the severity of asthma, such as, how often are you using your inhaler? Are you having symptoms every day, or how frequently? Are you waking up at night with symptoms? And so the doctor may just ask those questions, but there are also some standardized questionnaires that have some of these questions in them. And two of them are on this slide. One is called the Asthma Control Test, and one is called the Asthma Control Questionnaire. In my previous talk on asthma, I discussed how spirometry can be used to diagnose asthma. And this slide is just to show that you can use it to assess for if asthma is controlled as well. So in addition to symptoms, spirometry can also be used to assess response to asthma therapy. This is a busy slide that just demonstrates that there are different types of medications in the inhalers used for asthma. There are bronchodilators, which are medicines that open the small tubes or bronchioles in the lungs, and they allow for better airflow into and out of the lungs. One example is albuterol, which is a short-acting bronchodilator. There are also long-acting bronchodilators such as formoterol and salmeterol. And then there's a different type of long-acting bronchodilator known as tiotropium. The brand name of tiotropium is Spiriva. And so sometimes doctors call them by their medical terms. And for short, we say SABA, LABA, or LAMA. Steroid inhalers are another type of inhaler used to treat asthma. They reduce inflammation in the lungs and the lung tubes to improve airflow. The medical term for steroids in the lungs is inhaled corticosteroid. Examples are budesonide and fluticasone. So rescue inhaler recommendations have changed recently. A rescue inhaler is an inhaler that I use when I have asthma symptoms to rescue myself from those symptoms. So if I feel short of breath and I'm wheezing, I take 2 puffs of my inhaler to improve my symptoms. It used to be that only albuterol was used as a rescue inhaler, which is just a bronchodilator. But nowadays, they have done some studies that show that the steroid plus the bronchodilator, so like a steroid plus albuterol in one inhaler, or Symbicort in one inhaler, can be used not only just for maintenance, where you take it no matter what, but you can also use that same maintenance inhaler as a rescue inhaler. This is a busy slide, but basically all this slide is saying is that you have a steroid and bronchodilator inhaler, and if it's not working to use that just as a rescue inhaler, then the next step is to add it as an inhaler that you take all the time, what we call maintenance therapy. So if you're taking Symbicort, for example, as your rescue inhaler, then if your asthma isn't controlled, we may ask you to take the Symbicort twice a day, as well as needed as a rescue inhaler. And this is now known as maintenance as well as reliever therapy or MART therapy. And you should just know that that's what's kind of recommended now. It's a new recommendation. The maximum puffs, say, of this Symbicort inhaler should not exceed 12 per day. It doesn't have to be Symbicort. I was just using that as an example. If the asthma isn't controlled with the steroid and long-acting bronchodilator inhaler, the next step is to increase the dose of the steroid in the inhaler. If you get to the maximum dose of steroid in the inhaler, then we add something like Spiriva or a LAMA inhaler. And after that, if things are still not controlled, then there are these monoclonal antibody medications that can be tried. Monoclonal antibodies are expensive treatments used for more severe cases of asthma. An antibody is an immune system protein that is Y-shaped. It is one way for the immune system to neutralize threats like bacteria and viruses. Monoclonal antibodies, in contrast to antibodies that our bodies make, are made in a research or laboratory setting and used to neutralize certain target molecules floating through the bloodstream. So in the case of asthma, monoclonal antibody medications neutralize molecules that cause asthma symptoms. So this is a cartoon picture of what a monoclonal antibody looks like. They are Y-shaped and they grab these red things in the image there that I called bad molecule in the image. The medical term for the red thing is an antigen. So the antibody binds to or grabs an antigen and neutralizes it. So our bodies do this in response to infection. They spit out these antibodies from these white blood cells called B cells, and they neutralize viruses floating around and pieces of bacteria and stuff like that. But in the case of a monoclonal antibody, which was made in the lab, we can actually make these antibodies to our advantage to target one specific bad molecule, also known as an antigen. When the inhalers aren't working and there are 3 inhalers, a steroid and 2 types of long-acting bronchodilator medications on board, then we need additional therapy to control the asthma. And these monoclonal antibodies can serve as that additional therapy to treat severe asthma. You can see there the generic names are on the left, the trade names are in the middle, and you've probably heard some of these names on TV. There's Xolair, Nucala, Sinclair, Fasenra, Dupixent, and Tezspire. And they all target different bad molecules or target molecules that are implicated in asthma. So they help control asthma symptoms by neutralizing these bad target molecules. They're very expensive, and so we use them kind of as the last step of asthma treatment when the asthma is not controlled by inhalers alone. Anytime a patient isn't responding to their asthma therapy, we want to investigate why. We want to make sure that, first and foremost, that they have asthma. We need to listen to their story again and make sure that the symptoms match what asthma is. And we should then assess their inhaler technique and adherence. So are you using your inhaler when you're having symptoms, for example? If not, maybe you should be using your inhaler more often to get better control of the asthma. And also, are you using a spacer with your inhaler? Because spacers help um, put the medicine into this chamber before you breathe it in, so that you're not just spraying the inhaler into the back of your throat. You're actually breathing in the misted medication of the inhaler. And we also want to treat things that could make asthma worse. We call these comorbidities. OSA stands for obstructive sleep apnea. So making sure that patients are wearing their CPAP and doing their best to lose weight to treat the obstructive sleep apnea. GERD is gastroesophageal reflux disease, also known as acid reflux or heartburn. And so actually acid reflux can make asthma worse, so we want to make sure that's controlled. Obesity can make asthma worse, so patients may want to lose weight. Chronic rhinosinusitis is a condition where there's long-standing inflammation in the sinuses of the face, and this can make asthma worse as well, so we want to make sure that's treated. Anxiety or depression can sometimes make asthma worse. There's something called inducible laryngeal obstruction, previously called vocal cord dysfunction. It can kind of mimic asthma, so we want to make sure that patients actually have asthma and don't have what I used to call vocal cord dysfunction and is now called inducible laryngeal obstruction. Also, pollutants in the air can make asthma worse. So smoking, vaping, allergies, air pollutants, all of those can make asthma worse. We want to try to minimize those things. And then NSAIDs are a type of medicine used for inflammation and pain. And you know these medicines. There are things like ibuprofen, naproxen, also known by the brand names of things like Motrin, Advil, and Aleve. So some people, their asthma is made worse by taking these medications. So in summary, asthma is generally treated with a bronchodilator inhaler and steroid inhaler. New recommendations are to use a combination bronchodilator steroid inhaler as a rescue inhaler rather than what we used to do and just use a bronchodilator alone. So symptoms as well as a spirometry test can be used to determine whether therapy is being effective and whether we need to step up therapy. Monoclonal antibody medications are used for severe cases of asthma when inhalers alone aren't working. And anytime therapy isn't working, the lack of treatment response needs to be investigated. Thank you.